treatment of single type gingival recession in the lower jaw and especially in the lower incisor make me spend quite a long time because there is a difference in the etiology and difference in the surgical treatment. The story of this single type gingival recession in the lower incisors is almost always the same. We have patients that have undergone to orthodontic therapy in the past, almost always. At the end of the orthodontic therapy, all incisors were right position. They were split lingually with the wire, round wire, and for years, nothing happened. At a certain time, one tooth, sometimes two, but most of the time only one, experience a deep gingival recession that progress very, very, very rapidly. And the common characteristic to this gingival recession is when you look occlusally, this patient, you immediately realize that there is a change in the inclination of this tooth that along the main axis, so that the incisal edge goes lingual and the most apical third of the root gets out completely buccal. So it's like a torque movement of the tooth around the lingual wire that act as a rotation fulcrum around which the tooth can rotate. Typically, we see a reddish tissue all around the root, especially in the most apical aspect of this. And this is the attempt of the periodontal ligament to produce new tissue that try to be attached to the root, but the root is so outside of the bone, especially in the most apical third, that this tissue remain very immature. And when you touch the buccal aspect of this root, you feel that this root is completely buccal in the most apical aspect. You feel really the apex sometimes with respect to the adjacent one that are in the right original position. So there is no doubt that something different from toothbrushing, from erosion occurred. Great majority of the clinical case, there is no non-carious cervical lesion at all, and they are very rapidly progressive. What we should find in this patient is what happened that act cytospecifically at the level of this tooth to make this tooth pushed lingually in the coronal aspect so that it can rotate around the lingual round wire acting as a splint. Sometimes the diagnosis is very easy because you see the nails of your patient and they are used to bite the nails, and you can ask them to show you how they are used to doing, and you see that there is a site-specific pressure where the patient put the nails between the teeth of the upper with the tooth in the lower jaw. So this is extremely clear. You see, the only tooth where the nails act during biting is this incisor, who experienced the rotation and then the gingival recession. We have also found some other patients that when they are studying, they continuously bite pencil pen. And again, this is 5 years of university. They continuously push the incisal edge in lingual direction. Other that bite, they put the lip and bite the lip from the upper incisor to the lower incisor. But many cases, you can ask them if they do something strange, and you cannot find. In this patient, one possible explanation, because most of the time this patient has a quite deep bite, is that at the end of the orthodontic therapy, there was the palatal surface of one of the upper incisors that was overloading on the incisal edge on the incisors that experienced gingival recession. But since the orthodontist make the splint at the end of the orthodontic treatment most of the time without checking if there is a very uniform occlusion among the 4 incisors, the patient don't realize the overloading. There is no mobility of the tooth because obviously all teeth are splintered, and this trauma in times from the palatal aspect of the upper incisor towards the incisal edge of the lower incisors create the force that makes the tooth rotate around the lingual wire. Obviously, if this is the reason, we have to make some more complex orthodontic treatment in order to reduce the overbite or being sure that there is no overloading of this tooth once it has been repositioned. Because in this situation, you cannot make any surgical procedure. You cannot make any surgical procedure because if you open the flap to treat this gingival recession, you can find the apex or the tissue around the apex that is exposed completely from the bone. And so when you're going to make root planing of this surface, you may cut some lateral channel, very frequently located in the area close to the apex of the tooth. And so you can really experience some endodontic complication, and you also have to